Hey there, health enthusiasts. Welcome back to our channel. Today, we're unraveling the secrets of peripheral arterial disease, or PAD. But before we dive in, make sure you hit that subscribe button, ring the notification bell, and join our ever-growing community of health-conscious individuals. Ready? Let's go. Peripheral vessels, like the coronary vessels, can also be occluded by atherosclerosis. Peripheral arterial disease is common and associated with a significant risk of cardiovascular mortality, stroke, acute myocardial infarction, and limb loss. The vessels in the lower limbs are where this occurs most frequently. The distal perfusion pressures that are accessible to the impacted muscle groups change as a result of arterial stenoses. The incidence of peripheral arterial disease rises with patient age. The risk factors for this condition are similar to the risk factors for cardiovascular disease. Smoking, history of cardiovascular disease, diabetes, hypertension, hyperlipidemia, family history, sedentary lifestyle, tobacco use, chronic kidney disease. Patients with this condition can present in any stage of this progressive condition. Asymptomatic or masked peripheral arterial disease. Here the patient is asymptomatic but with risk factors for peripheral arterial disease. During examination, there can be reduced or absent peripheral pulses. Intermittent claudication. The patient presents a reproducible pain that occurs with the same distance walked or the same physical activity within the same muscle groups, and it ceases with a resting period of 2 to 5 minutes. Cramping or fatigue in the calf, thigh, or buttock during physical activity. The location of the pain is determined by the anatomic location of the arterial block. Most common in the distal superficial femoral artery, which corresponds to claudication in the calf muscle area. Aortoiliac area block causes thigh and buttock muscle claudication. In examination, palpation of pulses should be attempted from the abdominal aorta to the foot. There can be reduced or absent peripheral pulses. Auscultation for bruits in the abdominal and pelvic regions. Further assessment of the circulation can be made with a handheld Doppler device. This must be differentiated from neurogenic claudication, for example nerve root entrapment, spinal canal stenosis, venous claudication where a patient has a history of severe deep vein thrombosis or venous insufficiency, and musculoskeletal causes such as hip or knee osteoarthritis. The final stage of this condition is chronic limb-threatening ischemia. Here there is rest pain, which is pain with no activity, especially with limb elevation, and also nocturnal pain. Furthermore, there can be tissue loss, which can present as ulceration, gangrene, or necrosis. During examination, there are absent peripheral pulses, trophic changes such as hair loss, muscle wasting, clawed toes, ulceration which is punched out, sluey, necrotic. Gangrene presents with infection, blistering, abscess, skin breakdown, and finally necrosis. The Graz critical limb ischemia is a simple risk score. To identify patients at the highest risk for progression to critical limb ischemia, peripheral arterial disease is classified using the Rutherford or Fontaine classification. A useful method is the ankle brachial index, which is calculated as the ratio of systolic blood pressure at the ankle to systolic blood pressure in the arm. It's a recommended testing to screen patients who are at high risk of peripheral arterial disease. Less accurate assessment tool in patients with diabetes as the vessels undergo calcinosis leading to incompressibility. Use the toe brachial index in such cases. Review cardiovascular risk factors including blood pressure monitoring, lipid analysis, and screening for diabetes and renal disease. For patients with symptoms of peripheral arterial disease and an abnormal ABI, further diagnostic imaging is indicated. Duplex ultrasonography is the first-line investigation, with stenosis greater than 75% considered clinically significant as mentioned in RACGP, but angiography is a recommended imaging study. While catheter digital subtraction angiogram remains the gold standard for imaging peripheral arteries, it is rarely used for diagnosis because of its invasive nature and the availability of non-invasive imaging modalities. Computed tomography angiography is a second-line investigation used if aortoiliac disease arises following ultrasonography or for operative planning. Magnetic resonance angiography. The goals of peripheral arterial disease management are to decrease the occurrence of cardiovascular events and prevent death. Reduce limb symptoms, improve exercise capacity, and thus improve quality of life. Prevent or lessen disability and progression to limb loss. The methods used are lifestyle modifications, exercise and diet, pharmacotherapy for all peripheral arterial disease patients, and invasive revascularization for patients with limiting claudication or critical limb ischemia. The goal of medical management is to decrease the progression of the disease. Management given to all patients to improve survival and decrease the risk of cardiovascular events. Lifestyle modifications, smoking cessation. Pharmacologic. Antithrombotic, antiplatelet or anticoagulant therapy, aspirin and clopidogrel is recommended for symptomatic patients, or following intervention. Aspirin and low-dose rivaroxaban may be indicated for high-risk patients. If a patient is already on antiplatelet therapy for other conditions, antiplatelet therapy is generally not required. Ticagrelor is also not indicated. Antihypertensive therapy, ACE inhibitors S or ARBs, are considered first-line. Beta blockers are used with caution. Lipid-lowering therapy, statins. Glycemic control, tight glycemic control. Some studies show prescribing SGLT2 inhibitors has increased the risk of amputation. Diet and exercise. Management for symptomatic patients. To improve mobility, reduce amputation risk, and improve quality of life. Exercise programs are given for intermittent claudication or after endovascular therapy. For chronic limb-threatening ischemia, appropriate revascularization and foot care are required as first-line therapy. Self-guided exercise programs are recommended to be given. They can be done on a treadmill or outside for at least 45 minutes per day for 3 to 5 days per week. Ask them to walk at a normal pace until they feel pain or discomfort that is mild to moderate. Rest briefly until the discomfort passes. Repeat the exercise cycle, aiming to get to the same level of discomfort. They can move up to either a faster pace or up a hill when they can walk for at least 8 minutes without having to stop. In pharmacotherapy, we have cilostazol or pentoxifylline, which have shown some evidence to improve claudication. Foot care is especially important in diabetes patients. Regular 1-3 monthly foot checkups are needed. Manage preulcerative lesions such as heel callus, fissures, or thickened nails as indicated. Ask to wear therapeutic footwear. Early referral if tissue loss is identified. The final method is revascularization surgery. Indicated for severe, functionally limiting intermittent claudication, chronic limb-threatening ischemia, and suitable operative risk factors. The method depends on the patient's life expectancy and comorbid conditions, as well as on the extent of the occlusive disease. Endovascular therapy. First-line therapy for many. Balloon angioplasty or stenting to highly complex endovascular reconstructions that include atherectomy, or drug-eluting devices. Open surgery, for low-risk patients with suitable anatomy and failed endovascular therapy. Methods include peripheral bypass with autologous vein. Alright, folks, that wraps up our discussion on chronic peripheral arterial disease. If you found this information helpful, don't forget to give us a thumbs up, share this video with others who might benefit, and subscribe for more engaging content on various health topics. Thank you for tuning in, and until next time, take care of yourselves and each other.